So anybody know what an audible is in football, like American football? Like, when you come to the huddle, you come to the line, and anyone watch American football? Okay. I grew up, I don't play soccer, so please don't criticize me. But anyway, we're going to do an audible, which means that like Tom Brady, anyone hear of Tom Brady? Right, so half the time he's changing the play at the line before the ball is snapped. That's calling an audible when you see the defense is lining up in a particular way and they change the offensive play to address that. Instead of taking a break right now, we've decided that it may make sense for me to go and give my presentation and then take the question and before you finish. So if you could bring up my slides, or are they up? My slides, please. Just go. Do I have to do something? So if you think about the brain as the central processing unit of this whole process, it didn't make sense to many of us, and it wasn't even particularly based upon the term central sensitization. It didn't make sense that the spinal cord and brain, which is what central sensitization is about, was the only issue in chronic pain in general. It made sense to some of us that there has to be a story involving the peripheral nervous system, which I think certainly complicates things, but it also is in very much keeping with the theme of today's workshop, which is it's not an organ-based issue per se. And so the editorial that I wrote in response to that new tool that's been published is to not exclude other mechanisms, including those coming from this peripheral nervous system. So I'm going to do something really strange, which is not talk about pelvic pain for most of this talk. But I promise you, like a crescendo in a piece of music, there's going to be an ending. And I hope that ending is satisfactory, at least to those of you who came here to hear about pelvic pain. I'm not trying to be disruptive or contrary, although if you talk to my wife, she would tell you otherwise. And maybe even, I'm not that usually that way with you. But the point is to assist all of us in rethinking how we think about this subject. And I've also been told that I'm out of my mind by people, or we're worried about my career at different stages. So I understand. So this is who I am. This is what I do. These are my disclosures. These disclosures have absolutely nothing to do with pelvic pain, except not even. Just keep in mind the only disclosure here that has any relevance for this topic is that from Vertex. I was the lead investigator of an international study, phase 2 study that was just completed and was positive, demonstrating benefit of a new investigational agent in the treatment of small fiber neuropathy. If you're not that familiar with this term, how many people routinely hear the term small fiber neuropathy? Couple? Okay. You will be over the next 15 minutes, okay? Okay, so what I'd like to do during this time, and I don't have a lot of time, as much time as I would like, but no, none of us do, is talk about what that small fiber polyneuropathy is, talk about how we make the diagnosis, discuss the medical conditions that are associated with small fiber neuropathy. I promise you this is going to be relevant, okay? And then to talk about emerging treatments. So in general, at least in the US, in general, 40 million people plus experience a peripheral neuropathy. Peripheral neuropathies, that's the axons, the nerves that come out of your spinal cord. So they include autonomic as well as non-autonomic nerves. They're large fibers, small fibers based upon diameters. They're heavily myelinated. Myelin is like the insulation of a nerve. For those of you not familiar, it allows information to be processed faster. The less myelinated a fiber, the slower it conducts information. And increasingly recognized is the demonstration of small fiber neuropathy or small myelinated or unmyelinated fibers being involved. These are small fiber neuropathies. Why is this important? Because a person with a pure small fiber neuropathy is going to, how many of you ever, let me just digress for a second. How many of you ever referred a patient of yours with complex pelvic pain to a neurologist who came back and said everything's normal? Oh, that's only of you? Because the bedside neurological examination doesn't in any way or shape or form evaluate small fibers. Remember, we're building to a crescendo here, okay? All right, so please keep that in mind. So of course it's going to be normal, and that's why people scoffed at thoughts that we had about this area. So neuropathic pain, and this came out of Dr. Treat as a part of the German Pain Research Network. It was published in Neurology almost 10 years, more than 10 years ago, and this is a part of the IASP Neuropathic Pain Special Interest Group, which actually the meeting that I referred to earlier was the meeting of the Special Interest Group that was held in this very conference center 2 years ago. But pain, neuropathic pain is pain that arises as a consequence of a disease affecting the somatosensory system. In other words, it means pain coming from the spinal cord, nerves, or brain, not originating per se from a bone, muscle, or organ-specific condition. Can you tell me which person has pain? I mean, you have this horrible-looking knee on the right, you have a less horrible-looking knee on the left, and I'm going to propose to you, in the interest of time, that you couldn't tell me who has pain and who doesn't, because it has. But if everybody agree with that? All right, then why are we talking about organ-specific pain? Right? If we can agree, not being orthopedists, that a person can have terrible pain with a normal-looking knee, then why does it have to be the prostate that's causing the pain? I mean, I'm making that, but we just talked about that. And that's something that I'm coming to this. I promise you that there's going to be some evidence here. So widespread pain is what is sometimes the bane, as we say, of our existence. We see people with widespread pain. We may see, I think you made this point already, that a person may be seeing 10 different specialists for the same complaints, or the body part that specialist takes care of. But one other condition that has not been very well evaluated or written about, or we don't know of, we don't think about it in our daily activities, is the role of small fiber polyneuropathy in causing widespread pain and in some of these more typical diagnoses. Here are some neuropathic pain diagnoses. You all know about diabetic neuropathy, post-herpetic neuralgia, neuropathic low back pain, which is radicular pain or post-laminectomy pain, complex regional pain syndrome. You know about these. But what you may not know is small fiber neuropathy. So large fiber neuropathies you're going to see on an examination is the bottom line, a take-home message from this slide. Small fiber neuropathy is going to be very pain, sensory disturbance focused. We can use techniques like quantitative sensory testing. That's what QST stands for. I'm going to speak to you a little bit about intraepidermal nerve fiber density testing. But if you know the term EMG and nerve conduction velocity assessment, electrophysiological assessment, small fiber neuropathies are typically going to be associated with normal findings. And so that's what a typical neurophysiologist or neurologist is going to tell you when you send them their patient. I mean, how many people actually do good quality pudendal nerve studies? Not many. How many people really can use electrophysiological assessment in a routine setting to assess for the complex pelvic pain issues? Very few. And routine tests in the EMG nerve conduction velocity realm, these are electrical tests, are usually normal because they're only addressing large fibers. And there's a reason why we're talking about small fibers, I promise you. Now, what about small fibers? Well, small fiber neuropathies result from damage to the peripheral nerves, small unmyelinated C fibers or weakly myelinated A delta fibers. These fibers actually innervate both somatic as well as autonomic fibers. Thermal and pain perception is observed by these fibers. Enteric function, very important. Irritable bowel syndrome, enteric function, it's observed by small fibers. Large fibers are what allow you to perceive touch, vibration, position sense, big fibers. Anybody ever slam their fingers in a car door? Well, we knew you told me already, but anybody in the audience, or right? And what's the first thing that you do besides swear? Maybe you rub the area? Why do you do that? Because it feels better. Why does it feel better? Because touching activates large fibers. Large fibers get to the brain before small fibers, and naturally you're dampened. Okay? It's not rocket science. Okay? In neuropathic states, like in a diabetic neuropathy person, touching actually hurts because there's been a phenotypic switch to that touch now can activate pain. and we call that allodynia, and that's the hallmark of central sensitization. But there are also peripheral factors that can drive this as well, and we're getting to that. Okay, so it's traditionally speaking, the American Academy of Neurology provided a practice guideline several years ago which said that most small fiber neuropathies actually occur in a length-dependent fashion, meaning in the peripheral extremities and backwards and upwards. That's not necessarily true, and in fact, that was the purpose of an evaluation that Dr. Day and I undertook at Albany Medical Center and College several years ago. And so now we're going to eventually come to a very interesting data. Small fiber neuropathy can progress to large fibers. Muscle cramps are very common. Children actually also experience small fiber neuropathy. And a current colleague of yours, Dr. Day, Dr. Oaklander, has shown that very clearly. Quality of life is heavily impacted in small fiber neuropathy, and there are a number of different measurement tools to support this. Now let's talk about disorders which are associated. This is going to look, Dr. Potts, very similar in some ways to the slide that you showed, but I've got more slides about this than you. I'm not being competitive in any way. I'm just saying it's similar, but it's not the same. So there are many disorders that are associated with small fiber neuropathy, including impaired glucose tolerance, sarcoidosis, HIV, B12 deficiency, thiamine deficiency, all very different chemotherapeutic drugs. Gluten intolerance is one of the most common. 60-something% of people with celiac disease or gluten intolerant present with small fiber neuropathy. They've been going to doctors and providers for years, being laughed at. Work done at Columbia Presbyterian and published in Muscle and Nerve shows almost 60%. Different idiopathics up to 50% weight. There's more. There's some overlap to what Dr. Potts presented in terms of central sensitization. EDS, one of the best discoveries if you're an EDS sufferer or you know somebody with EDS. People with Ehlers-Danlos syndrome, there's a European group that published this work several years ago, 2 Italian groups, and then we noticed this as well in the United States in our group, that multiple people who present Ehlers-Danlos syndrome, which is a connective tissue disease, were being laughed at for coming into people's offices and sent out because they had pain, they were drug seeking. Why, how could you have pain? It's a non-painful condition. There's no basis for your pain. And the majority of people with EDS have biopsy-confirmed small fiber neuropathy. They're hereditary. Central post-stroke pain, we were the first to publish this observation that people with thalamic pain or central post-stroke pain had biopsy-confirmed small. It wasn't only about the central nervous system. The nervous system is more complex processing system than any supercomputer. It takes both the central and the peripheral nervous system to work with each other. Some people, you can't argue that it's top-down only. It's not central down to peripheral or peripheral up to central. It's different in different people, and that's really important. Oh, there's more. These are more. And actually, what led to the discovery of a NAV, and sodium channels are divided into voltage-gated subtypes. Steve Waxman at Yale and others proved that different sodium channelopathies could be inherited and be the basis of pain and erythromelalgia in small fiber neuropathy. And in fact, what Vertex is developing, and I'll disclose because I was the lead investigator and it's very interesting, is a NAV 1.8 blocker to help people with painful small fiber neuropathy. So this is not just pie in the sky. There are actually new treatments being developed, and I think it's relevant to the group that's in this room, because I'm coming to that point in just a second, okay? So, possible sodium channel mutations. There you see down in the next to the last bullet, the importance of NAV 1.8. These are all have been genetically confirmed. This is part of an evaluation of people who we take care of with chronic pelvic pain, chronic pain of undetermined cause, because we're seeing that more and more people are biopsy confirmed and proven to have small fiber neuropathy. Symptoms vary, but most often they start with just vague sensory disturbances. There may be pain in a particular, we've taken care of one person who had her gallbladder removed without any need to have her gallbladder removed when she had a more visceral centered small fiber neuropathy. Burning pain in the extremities, sometimes severe allodynia, hyperosthesia. Socks may be painful. Symptoms are often worse at night. There are autonomic and enteric function. And the most important thing maybe for this group is erectile dysfunction may be present. Abnormalities in sweat, GI symptoms, constipation and diarrhea, changes in urinary frequency may be present. You have so many acronyms.
Persistent genital arousal disorder in women, right. Unwanted clitoral sensation.
Right. So this is going to build in relevance because these are symptoms that you're evaluating. And I don't know how many of you are considering your patients to have this condition. And when you examine the person, they're normal because the bedside exam and that we routinely use are normal. So we have to think about ancillary testing. Many of these tests are going to be normal. So skin biopsy and quantitative sensory testing can be used to help diagnose. Okay, these are just questionnaires we can come back to if you have questions about it, but the skin biopsy has become a widely accepted technique to assess for small fiber neuropathy. It's a 3 millimeter skin punch biopsy tool. We usually use the lower extremity, doesn't matter what extremity you use at this point. You just have to have normal control in your laboratory, but you're looking at the intraepidermal nerve fiber density. It's normal. Anything below normal, remember, the small fibers tend to be helpful in modulating and fine-tuning the system. So anything below normal is considered consistent with the diagnosis of small fiber neuropathy. So a double negative, right? A negative times a negative is a positive. Most of the nervous system is designed to help fine-tune things. If you have a loss of fine-tuning nerves, you have exaggerated function, exaggerated activity. And it's one way to look at it. But it's the reduction of nerve fibers, intraepidermal nerve fibers per millimeter, that is how you make the diagnosis. Oops. And so, the skin biopsy has really become the way that we do this. This is work done in shingles, postherpetic neuralgia pain. Those with postherpetic neuralgia actually had a reduction in intraepidermal nerve fiber density compared to those who had shingles without postherpetic neuralgia pain. This is work done by Anne-Louise Oaklander at Mass General. You can use now corneal confocal microscopy. There are some centers that are using this as a non-invasive, especially outside the United States. This is being used increasingly instead of skin biopsy. So for those of you who are familiar with this technique and have people who can help you with this, there's still some controversy about this, but this is another way of doing this. These are more functional and imaging assessment tools that have been documented as being particularly helpful in looking at small nerves. These are blood tests that you would want to look at. Why is this relevant? Because there's an old proverb in our world, which is treat the treatable. Can you imagine being able to identify a particular medical condition that underlies your patient's chronic pelvic pain, such as B12 deficiency or others, or identify that they have celiac disease? I can tell you that every year we identify at least 20 people who didn't know they had glucose intolerance, who have hemoglobin A1Cs over 6 or 7. These are relevant. We're the ones diagnosing their diabetes. Okay, and there are many different. I can come back to this point if you'd like to talk about this in more detail. We do lumbar punctures on each person, just to be complete in terms of diagnosis, and in case we can't identify through blood tests a specific etiology. And these genetic issues have become increasingly relevant. And if everything comes about negative, we are now sending people for sodium channel genetic testing, especially because it's becoming relevant to treatment. So this is a rat that's been involved in an antidepressant trial. I mean, no disrespect to behavioral care, but the treatment of small fiber neuropathy is somewhat disappointing. It's not as disappointing as the rat hanging itself, but we still have a long way to go. And I think I think we'd all agree, recognizing the breadth of conditions that can cause a particular clinical phenotype is one important step in trying to treat somebody. How many people have ever used gabapentin for diabetes? Okay. Do you know that I'll give you the big blurb on this. These were sister studies. This is in diabetic neuropathy. Postherpetic neuralgia had a similar study in the same issue of JAMA in 1998. In each study, people started with a 6.6 out of 10 pain intensity scale. On average, 30% pain relief was seen in people who received gabapentin. That was better than placebo. 30% of 6.6 is around 2. If you subtract that from 6.6, you get 4.6. That means that the mean pain intensity at the end of the study for most people was 4.6 out of 10. Great. Why am I telling you this? Because to get into the study, you needed 4 out of 10 pain. That meant that you could complete the study successfully. Many of you raised your hand that you're using gabapentin, and you still qualified for the study. It's not as bad as that rat, but it still means we have a long way to go in treating people, and it's not about medicine only. So treatment is, we have a long way to go. These are the NUPSIG, Neuropathic Pain Special Interest Group International Studies, International Study Group for neuropathic pain, but not specifically for small fiber neuropathy. So intravenous gamma globulin is in fact an emerging treatment. I'm not suggesting it for chronic pelvic pain because I haven't gotten to chronic pelvic pain, small fiber neuropathy yet, have I? But I'm getting there. But this is an emerging treatment. And this is a study of sarcoidosis patients in which several patients were treated successfully. Here's another study of IVIG and Sjogren's syndrome. This is another patient with evidence on their diagnostic assessment of autoimmune disorder associated with their small fiber neuropathy. 16% were in remission after multiple treatments with IVIG. And this is really super important because many of the patients who you're seeing, I know in Europe, I believe that fibromyalgia is not used as a diagnosis as often, maybe, as the United States. That may or may not be true, but this is compelling data. About 50% of people who have been diagnosed with fibromyalgia, and I've written an editorial about this too, an invited editorial about this too, actually have biopsy-confirmed small fiber neuropathy. What does that mean? We actually showed that there are peripheral abnormalities in the skin of people who have been diagnosed with fibromyalgia. So it's not only a central issue. I know that's blasphemous. I've been told by colleagues that's blasphemous because fibromyalgia is a central sensitization disease. But 50%. So that's the top is from Mass General and Harvard Medical School and Louise Oakland. 41% of people had positive skin biopsies who were diagnosed with small fiber neuropathy. This is a European study done in Germany by Claudia Sommer and her colleagues, and over 60% had. And a retrospective study that was done, an observational study also showed over 60%. Now here is work that Dr. Day and I undertook. We were not sure. We basically took the point of view we didn't know. Is there overlap between small fiber neuropathy and chronic pelvic pain? And so we looked at 39 patients, and 25 of them, we didn't choose them, or consecutive. Dr. Day did the intake and offered this opportunity to be further evaluated. I think most patients said okay. Almost 2/3 had demonstrated skin biopsy findings consistent with small fiber neuropathy. This is the crescendo. This doesn't mean that central sensitization isn't an issue. It means that your whole nervous system, your whole body is an issue. Comorbid conditions, GERD, 46%, migraine, 38%, IBS, 33%, fibromyalgia, 38%, endometriosis, 15%, IC, 18%, other chronic pain syndrome, 36%, and vulvodynia, 5%. This is what we have shown. This is not, we didn't make this up, we didn't hypothesize this. We continue to do this. And it's consistent. Almost 2/3 of people who present to us unannounced with chronic complex pelvic pain have biopsy-confirmed small fiber neuropathy. This is a handbook that we created, colleagues around the country, United States, including myself. If you like the artwork, that happens to be my daughter's artwork, but that's besides the point. But this is a handbook for people with small fiber neuropathy. We don't make any profits on this. It was done to help people who have the condition understand their condition. And with that, we don't understand everything about small fiber neuropathy. But for this workshop, I think it's very, very important to think of it as a relevant diagnosis. And we're open to discussion about how it might play a role in your practice going forward. Thank you so much.